Okay, welcome along to Menopause Month. Today I am speaking to Victoria Howell. Victoria, do you want to just tell us a bit about what you do?
Yeah, sure. Thank you for inviting me along. So I'm a menopause and women's health nurse. I run clinics, so I see people in the clinic and we have a consultation and then we have a follow-up a couple of months later. But I also provide education for primary care clinicians, get my words in the right order there, primary care clinicians, with regards to advising them about something that we're going to be talking about later today with regards to vulval health checks, etc. But also I do menopause awareness in the workplace, menopause support and talks in the workplace as well. And I've been doing quite a bit of health writing lately too. So yeah, that's me.
So, given that it's Menopause Month, we always use this as a bit of a free-for-all to talk about lots of topics. So we're going to look very particularly at vulva health today, which is just an area that no one talks about.
Yeah, absolutely. Absolutely. So many people get the vulva and vagina mixed up. So just to sort of clarify right from the start, the vagina is inside, so you don't actually see your vagina. That's the bit that's up, and the bit that you do see, but not very often because of the anatomy, is your vulva. So just to give one of my diagrams here. Now, I am not an artist. I am very much a nurse, but I don't know if you can see this diagram.
Yep,
So
got you.
this is a diagram of a vulva, okay? So the part that you see here, that's the vestibule that leads into your vagina, okay? So up there, so that's your vulva. So that's the part up there, which is the vagina, okay? So it is still taboo, unfortunately. You know, you and I, we work in the world of menopause, so nothing shocks us these days whatsoever. And we're not afraid to talk about anything because our aim is purely to educate and empower women.
And to normalise it actually as well, so that people don't feel embarrassed to go to their doctor. It's something that I know, I see time and time again that people go, oh, I don't really want to go for my smear test or for whatever because, oh, I'm a bit embarrassed about the doctor seeing. And it's like, for the doctor, that's just another part of the body. It's as embarrassing as your finger or your nose or your ear, isn't it?
Absolutely, yeah. As far as the doctors, whether the doctor's male or female, whether your practice nurse is male or female, to them it's just another part of the body, like you say, no different to the finger or anywhere. Health professionals aren't embarrassed about it. They're there to do a job and to make sure that that's done properly, the screening, etc. So yeah, they're not embarrassed.
Exactly, and I do totally understand that for a lot of women it feels very intrusive and it can feel embarrassing, and this is why we need to talk about it. It's why we just need to keep talking about it, isn't it?
We do, absolutely. And this is why I aim training at primary care clinicians, because even to this day, so many do not know about vulval skin conditions. Okay, so many people are misdiagnosed. So they'll go to the doctors and they'll say that they're burning, they feel sore or itchy, and the doctors are not examining these ladies. So they're just prescribing them medication for thrush, prescription, go and take that for a couple of weeks. Yeah, so, you do what the doctor says, and then some women, and one in particular who I will refer to quite a bit in this session, the lady who founded Vulval Cancer UK Awareness, Claire Baumhauer. She is brilliant. Everything that this woman has been through, she shares her story. She's such a patient advocate and she wants change, and she wants clinicians to be educated as well. And do you know what? Clinicians themselves, if they don't know, they don't know. We know what we know. So if we were to go to a doctor's surgery and give them some CPD on, you know, we're going to do like a 45-minute session on vulval skin conditions, they would embrace it, and I'm sure they would put it into their practice.
Of course.
You know.
So let's say somebody's presenting with what on face value looks like it might be thrush, or it might be bacterial vaginosis. You know, those are the two kind of obvious things that might get diagnosed. I'm going to sneeze. What might be going on, and what are the things that women can be looking out for to check for themselves, so that they for themselves can see that it isn't necessarily recurrent thrush or recurrent BV?
Exactly. So I think the thing is for them to consider when they had it, when they got the prescription for thrush, if that was what they were given. Hopefully it wasn't, but it happens. And did it clear up? Did it clear up 100%? Or did they find out, you know, did they go a week or 2 weeks, and did it sort of those symptoms start creeping in again? It's a case of really writing down those symptoms, keeping a record of those symptoms and how it affected you on particular days, because whatever your hormones doing at the time, that can obviously affect as well. So I would say to give it a few weeks. If it continues, and if it keeps continuing, and if you go back and they say have this for thrush again, you've still got thrush, I would be bold and just say, well, can you please examine me, because I'm aware of a variety of vulval skin conditions, and I know that thrush is one of the most misdiagnosed problems. So that's there's a nice way that we can sort of ask our GPs, ask our practice nurses, say, you know, I would really like it if you could do an examination just to check that everything is okay down there. You know, they can always do a swab, you know, because it may indicate an STI or something like that. It could be that, but also it could be a number of vulval skin conditions. Vulval dryness, vulval vaginal atrophy isn't just for women who are postmenopausal. For some, it's the first symptoms that they experience of their perimenopause. So I'll go into that a little bit more detail, shall I, while we're here? And again, this is one of my wonderful drawings. So this is a very basic drawing of your vagina, okay?
Yep.
So one side, it's nice and plump, and the line, you know, it's nice and full.
Yep.
Now, when we don't have enough estrogen in our body, so this can be through the perimenopause, you know, we notice our skin drying in other places, like our face. We always think, you know, we must slap some cream on because we're concerned about what we look like, etc. But we can't see what's going on inside. So it's the happening inside as well. So this side is when it's got too dry and when it's got atrophy. So it gets really thin. So it loses all the moisture and all the lubricant in there. So if you imagine both sides like this, they're both thin. So there's nothing there to sort of like plump it out like a nice pillow or something. So that can make intercourse really painful. It can cause bleeding during intercourse as well. And I think it was Jane who wrote Me and My Menopause Vagina, which I think, yep, spot on. You've got a copy of that.
Copy here as well.
Yeah, we all need a copy of that. It's fantastic. So if you think that this is my hands, the vagina, and they're nice and plump like that, but then that's gone, and it can rub as well, and that can also go extend to the vulva too. So it can be burning when you go for a pee. It can be sort of patchy. It can be really sore. And the other thing is, the vulva can start to look different too. Okay, so before I go into how to examine our vulva, I will talk about other skin conditions of the vulva as well. I mean, lichen sclerosis is also misdiagnosed. So we were talking about thrush. More often, or a lot of women who are misdiagnosed with thrush may actually have lichen sclerosis, which is a skin condition that we can have anywhere on our body, okay? But when it's on our vulva, that's where obviously it causes an immense amount of pain, and I will go into some other symptoms. But not just that, there's a small percentage of women who have lichen sclerosis who can go on to develop vulval cancer, which is why it's really important that women know what their vulvas actually look like. You know, they go and say, hi, meet it, see what the baseline is for us as individuals. So then when we're checking it each month, we know what the normal is. So then we can identify any change and we can report that to the GP or practice nurse straight away. And because you've been keeping a record of what it looks like, may not be a written record, but you know, your visual record, you think actually this wasn't here before, or I didn't have these tears or cuts before. So that's why it's really, really important to check the vulva as well.
Absolutely.
So,
And it all ties in with everything that I'm always saying about tracking. It comes under the whole keeping on top of what's changing in your body.
absolutely.
I was just going to quickly say, when you mentioned the experience of getting burning when you pee, a lot of women, if not sent down the thrush route, at that point sort of find themselves in the UTI cycle, don't they, with antibiotics? And again, that needs looking at, not just immediately just prescribing something.
You're absolutely right. So many women are just given trimethoprim or whatever antibiotic. You've got a UTI, you know, you've got symptoms of a UTI, but it's recurrent and it goes on and on and on. And you think, actually, no, a bit of topical, you know, estrogen down in the vagina, that could, you know, eliminate all of that. And that would prevent the atrophy occurring as well. Because while they're going through these recurrent UTIs, the damage is being done to the tissue down there. So no, you're absolutely right. Tracking is so important. And I get all my ladies to track their symptoms. Because we're all busy people.
Yep.
If I had a migraine last week, I wouldn't remember what day it was. I wouldn't have remembered how bad it was, you know. Whereas if I've spent 2 seconds just writing it down, then looking back over the month or months, it's really easy to identify patterns and triggers as well. So no, I'm absolutely 100% with you. It's so important.
And obviously, add into the fact that women in perimenopause have zero memory anyhow. We've got to write it straight down. We're not going to know what happened last week.
You're letting my perimenopause symptom out, aren't you? Brain fog is the biggest one for me, most definitely. Absolutely, without a doubt.
I was just going to say at this point, this book, honestly, anybody who is struggling with any of this, read it. Jane, who wrote it, I mean, pretty much went to hell and back with her symptoms. And it's, I've heard her speak as well, and she's an amazing lady. And we all should know about that. Even if it's not yet happened to you, even if it never happens to you, we should all know about that.
Absolutely. As Jane says, anyone with a vagina should read it. You know, the way, what she went through, she has been to hell and back, like you say, but the way the book is written is light-hearted and it's captivating, but it doesn't take away the severity of what she's been through either. So yeah, definitely. And if you've got partners, get them to read it too, so they can understand what you may be going through. Most definitely. Yeah,
absolutely. So were there any other bits that you wanted to touch on around this part, or are we basically telling everybody they should be reading this book?
I think so. Since I've been doing a bit of work with Jane and a bit of work with Claire Baumhauer from UK Vulval Cancer UK Awareness and Emma Norman, basically that's what has inspired me to train clinicians in primary care. Okay, so that's why I've written an article about it, which is coming out in the autumn. But one thing we need to do, we check our breasts once a month in the shower. You know, it's Breast Care Awareness Month as well as Menopause Awareness Month. We've got a busy month, us women. So as well as checking your breasts, always check your vulva at the same time. So what Jane always says is to get like a magnifying mirror, like a shaving mirror that you can just pop down on the floor in front of you. Then you've got both hands free to check. So what she says is to use one hand, and there's my drawing. So is that clear? To use one hand, and like you got your major labia here and your minor here, and just sort of gently pull it out so you can see what it looks like. You can see how thick or thin the labia is. You know, have a look at the clitoris area, at your urethra, and see the opening to your vagina there, because that might indicate an early sign of a prolapse or something like that. So, and it's a case of looking what you've got and signs to look out for. So, as I said, lichen sclerosis. So what you're looking for is any white patches, okay, any itching or burning, any splitting or tearing, particularly if you've had an episiotomy through childbirth. That could be an area where you may tear because the skin integrity isn't as, you know, robust as the other areas. Fusing of the labias as well. So it may look like there's no differentiation between your major and the minor. Now, some people find that their clitoris gets buried under the skin, so you can't actually see it either. Another symptom is what they describe as shiny or crinkled skin. Okay, and painful intercourse can be a sign of lichen sclerosis as well. So you don't have to have all of those symptoms, but one of those symptoms may indicate that, okay? And it can be uncomfortable to sit down as well. So going one step further, so the vulval cancer, so some of the symptoms sound similar to lichen sclerosis, but of course the severity may look different, who knows. So you may find white, red or dark patches that you didn't have before, okay? You may have an ulcer or a sore or a tear, which you could have with lichen sclerosis, but with vulval cancer, these sores and ulcers don't go away, they're still there. So if you've experienced something like that, it's still there 4 weeks later, go to the doctors and insist on having an examination, okay? Again, any bumps, someone may have had a cyst there sort of all their life, but then if that's changed, you know, just like if we have a mole on our skin, we're always told to go and get it checked if it's changed. So the same thing, also itching and burning, an unusual discharge, bleeding between periods, and bleeding after the menopause, so postmenopausal can be a sign as well. And the risk factors for something like vulval cancer could be lichen sclerosis. It's a very small, so if you are ever diagnosed with lichen sclerosis, please don't give yourself a death sentence and say, oh, I've got this. It's not necessarily going to happen, okay? And it's all about monitoring and getting the right care with a vulval skin dermatologist. HPV, some of the strains of HPV can go on to vulval cancer. And women who have had radiotherapy for uterine cancer can potentially go on to that too. But this is why it's important to check, because if things change and if we're checking, we can get it seen to, and we can get it seen nice and early, so it doesn't
Exactly.
become
And it's exactly like checking your breasts. You know, if you find a lump in your breasts, you get referred, they check it out, and you know, if you've caught it early, they check it out, they deal with it, and you're done, aren't you? And yes, as with everything, there can be the exceptions to the rule where it's already nasty. I get that, but taking control of our own bodies, tracking our own symptoms, following what's happening, and not just writing it off to being the obvious thing if it keeps coming back. I think that's the key
yes,
thing. If it's thrush or a UTI that doesn't clear up with the standard treatment for that thing, it needs further investigation.
it does. Absolutely. Yeah, very well said. Absolutely. Yeah.
And also, every single woman should read Me and My Menopausal Vagina by Jane Lewis. It's very rare that I really recommend a book, but that one, honestly, is brilliant. And when you read it and you understand the levels of pain that Jane was in, you'll understand why Victoria and I are so keen that you should get this dealt with quickly before it becomes a problem. Because Jane genuinely, I mean, she couldn't wear jeans, she couldn't sit down, she was in agony constantly.
Absolutely.
I
I
mean,
mean, she
horrible.
loved her horse, didn't she? She used to love riding, and she can't ride anymore. And even though she says she's in a much better place than she was previous, um, it's just really sad. But she is such an advocate. She really is an amazing woman, and she'll introduce herself, and quite often on her live she'll say, I'm not a medical person, I'm not this, I'm just. So when I next have a live with Jane, I'm going to be saying, you're not just anything. You are not. You're so not. She's amazing. So it's people like her that helps us to do our job, you know, to help us carry on and raise awareness for women, to empower them, like you say, to track everything, to be aware of things, and then they can make the right choice for what is right for them. Yeah.
So just quickly to round up, I'm just going to run through the different things, and if you can just tell me what the doctor could prescribe for those things or what the course of treatment might be. So thrush would be potentially just an over-the-counter thing, or if it's serious, then pessaries from the doctor or creams.
Absolutely. And this is another reason. That's very good that you've prompted my memory there. That's a very good reason, because a lot of women, if they're having these symptoms, they'll just think, oh, I've got thrush, and they won't go to the doctors.
Yeah.
And if they've got thrush, so it's so important that they do get checked by a health professional. Absolutely. Yeah.
So thrush, if the over-the-counter stuff isn't working, go to the doctor. Bacterial vaginosis, again, go to the doctor. If the treatment isn't working, go back and ask. Recurrent
Absolutely.
UTIs, again, if the antibiotics don't clear it, go back. And with all of those, you may be looking at vaginal atrophy, in which case localized estrogen will help, or you may be looking at lichen sclerosis, can't say it, lichen sclerosis, in which
You
case,
said it.
am I right in thinking it's steroid cream?
It is steroid cream. Now, some GPs will give a patient a 2-week, course of steroid treatment, but it needs long-term management, which is why, if your GP either talks to a vulval dermatologist on your behalf, or I would ask for a referral, because they're the people who will know what regime will work for you. And if something doesn't work right for you initially, you have your review with your vulval dermatologist, and make sure that they can change it for you and try different brands, different types, strengths, etc. But it is an ongoing medication regime, definitely.
And then obviously if it gets as far as vulval cancer, then that's a whole different ball game, and you're then into the oncology area.
Absolutely.
And they sort that out in their own way. But for the first 4 of those, so for thrush, BV, recurrent UTIs, and lichen sclerosis, your first port of call is your GP, and tell them what the changes are.
Absolutely. Absolutely. And like I say, on Vulval Cancer UK and Lichen Sclerosis Awareness website, you can download these for free. So they give you the advice, sort of gives you an idea of what to say to the doctor, as is, you know, the ones that Jane has on her website as well, gives you a lot of information on there, and, you know, it gives you a little bit more knowledge to take to the doctors with you. And most GPs, they will listen. Not all, but they need to listen, because ultimately it's all about patient care, and we need to do the best for our patients.
And ultimately, as I say all the time, we know our own bodies. The GPs only have 10 minutes with us. We can always help them by turning up with our tracking, with our thoughts of what it might be. So yeah.
Absolutely. Yeah.
Awesome. Thank you, Victoria. That's been really, really helpful.
Very well.
Thank you.